Welcome, everybody. We are just waiting a few more seconds so that we can allow all participants to join. Thank you.
Okay, I think we can start. Good evening to everybody. I'm Giovanni, the ESSM president. So next, first of all, I'd like to thank our sponsor, in particular IBSA, for giving us an unrestricted grant to support our educational activity. So next, I'd like to remind you that, as always, the webinar will be recorded and will be available in our website very soon. Next, as I told you, as a past webinar. Next. Carlo Bettocchi, our past president, cannot be here, just to bring you year's greetings for a successful meeting. Obviously, I'd like to invite you to Bari next to our Congress, annual Congress. I'd like also to thank Mikkel for its amazing activity during the preparation of the Congress. So next. And again, thanks to IBSA, our sponsor. Next. I'd like also to remind you that we are running another very interesting wave of our school, starting very soon in Budapest, as always. Next. And also this year, we are running a new educational project called EFUS, specifically dedicated to the role of female ultrasound in evaluation of female sexual dysfunction. And again, the school will be run in Budapest. Also, we are defining the second phase of our surgical educational activity. So the academy, the first step have been already done, and we are running and we are selecting the people who can join the last part of the educational project. Next. Then I'd like also to remind you that we are till the end of the year, we will have two different webinars. One related to our young guys, so Josema, along with Dentog, so gynecologist. And the last one will be on 18th of December, again from 8 o'clock and 9 o'clock. Finally, for sure, I hope that very soon, especially in 2024, we will have the publication of the update publication of the Manual of Sexual Medicine, the syllabus. I'd like to thank Kobe and all Nicola and the people who are working on it, and I hope that the book will be presented soon. Next. Finally, again, I'd like to introduce the chair of our educational committee, Daniar Osmonov. I'd like to thank him for his amazing work. Please, Daniar.
Thank you, Giovanni. Get well soon. So today we will talk about nutraceutical therapy in the male health, in the man's health, and we have two outstanding speakers today. This webinar is supported by IBSA. The first is Dr. Barbonetti, and his topic is current evidence of nutraceuticals. The next speaker is rising ESSM star, Dr. Gomez from Spain, and he will explore the topic between the hope and reality, the place, value of the nutraceuticals in the non-surgical treatment of erectile dysfunction. Thank you very much. Enjoy the webinar. And thank you once again, IBSA, for support and supporting our activities. Please, Dr. Barbonetti.
So we will now start with the first presentation, which we are uploading.
Maybe to have your attention once again, if you have any questions, please use Q&A section, not the chat, Q&A. Thank you.
Dear colleagues, I would like to thank my moderator for the presentation and Professor Corona for trusting me with the challenging task of speaking on a topic that is typically controversial in andrology and even more so in aging, when the focus is not so much on infertility but on erectile dysfunction. Indeed, the interest in the use of nutraceuticals in erectile dysfunction has increased over the past 30 years, and it remains very high. As a possible explanation, all the phosphodiesterase type 5 inhibitors are the drugs of first choice. There is a non-negligible rate of discontinuation with these drugs. In this meta-analysis by Giovanni Corona, phosphodiesterase type 5 inhibitors were associated with a mean monthly discontinuation rate of 4%, that is almost 50% after 1 year. In meta-regression analysis, the discontinuation rate was higher in studies enrolling younger populations and in those carried out in samples with higher prevalence of hypertension and diabetes. In addition to comorbidities, Corona study identified other main reasons behind dropout, mainly the loss of efficacy, cost and side effects. Overall, these limitations encourage the search for different approaches that could combine more favorable compliance and safety with efficacy and more affordable treatment. On this basis, the nutraceuticals market is projected to double in less than 10 years, with an annual growth rate of more than 10%. Nutraceuticals actually combine a good safety profile with mechanisms of action that directly or indirectly can improve erectile function. Some of them are involved in the molecular pathway of nitric oxide synthesis. Other molecules play a role more downstream, acting in synergy with cyclic GMP or reducing its catabolism. For some substances, the theorized effect is to promote the synthesis, bioavailability, and activation of testosterone, which in turn is involved in the molecular pathway of erection. However, the vast majority of nutraceuticals act as antioxidants, counteracting the effects of free radicals that play a key role in triggering of endothelial dysfunction, particularly the superoxide anion that inactivates nitric oxide to form peroxynitrate. With this in mind, nutraceuticals and antioxidants could provide the greatest benefits precisely in the elderly. In fact, it is well known that systemic biological markers of oxidative stress progressively increase with age, accompanied as a cause or a consequence by a depletion of antioxidant defenses. So, there is a rationale for the clinical use of antioxidants and nutraceuticals in the management of erectile dysfunction, but what is the evidence of effectiveness? In this recent meta-analysis, at the overall combined estimate, the administration of antioxidant compounds to patients with erectile dysfunction was associated with a nearly threefold aggregate mean increase in the erectile function score. However, extreme heterogeneity was evident. The heterogeneity was related to large differences among the studies, not only in the type of enrolled populations and the severity of erectile dysfunction at the baseline, but also in intervention design and protocols, varying in nutraceutical type and treatment duration. All of this greatly downgrades the quality of the evidence. This evidence was found, indeed, to be insufficient to recommend the use of nutritional supplements in the treatment of erectile dysfunction by the recent consensus statement of the Italian Society of Andrology and Sexual Medicine. In fact, determining whether nutraceuticals are really effective in the treatment of erectile dysfunction, and more importantly, whether among all those available there are some that are more effective than others, is not easy at all for at least two main reasons. First, for each type of antioxidant, the evidence of efficacy is derived from the results of only one study or at most 4 or 5 studies, and thus meta-analysis provide an overall class effect but not related to individual molecules. And more importantly, head-to-head studies that have directly compared different treatments are rarely available. Against this backdrop of uncertainty, the statistical approach of network meta-analysis finds its natural field of application. It is a relatively new tool that is beginning to find its recognized place in the field of evidence-based medicine, designed to compare, through a rigorous methodological approach, multiple treatments in a single statistical model by providing a hierarchy of efficacy that is useful in driving clinician choices. From a theoretical point of view, the network meta-analysis can operate in cases where two situations are realized. Wanting to perform the comparison between two treatments A and B, there is no head-to-head or direct comparison clinical trial between the two. Instead, there are some controlled trials in which a third intervention, for example a placebo, has been compared with both A and B. Network meta-analysis is able to provide information on the A versus B comparison using the results of available trials by means of a new statistical method called indirect comparison. Precondition for the application of this analysis is that only randomized controlled trials are selected and that all trials included in the network of comparisons employed the same inclusion criteria and evaluated the same endpoint in the same manner. Adherence to these principles guards against the risk of inconsistency corresponding to heterogeneity in traditional meta-analysis, in the presence of which the assumption of transitivity, which is essential in network meta-analysis, cannot be fulfilled. So, I therefore tried to apply this methodological approach to the study of nutraceuticals for erectile dysfunction. A particularly inclusive search string was developed to identify a total of 51 articles, of which 16 meet the inclusion criteria. In particular, all studies other than randomized controlled trials and that used diagnostic tools other than International Index of Erectile Function were excluded. The geographical area of the studies covered Europe, the Middle East and Eastern countries with no USA representation. Included trials evaluated improvement of erectile dysfunction of different etiology in a total population of 1,090 men with a mean age of 52 years. These patients were assigned to placebo or one of 13 different nutraceutical preparations for 4 to 24 weeks. The quality of the included studies was evaluated using the Cochrane Collaboration Recommendations Assessment tools. Overall, among the 16 trials, 11 were classified as having a low risk of bias, 2 had a high risk, and 3 a moderate and clear risk of bias. At the network plot, it was evident that a few preparations had been directly compared head-to-head. As a first step, all active compounds that had been compared at least once with placebo were included in a pairwise meta-analysis. As you can see, Through the traditional meta-analytic approach, several treatments showed significantly higher efficacy than placebo. Of these, as expected, the most effective were those that included a phosphodiesterase type 5 inhibitor. However, all the limitations of the pairwise meta-analysis are clearly evident. Only 1 or 2 trials are available for most treatments, with the exception of L-arginine, which was tested in 4 studies. This results in an overall estimate reflecting the class effect, which is unfortunately burdened by a high heterogeneity. So, the fact that each treatment had been compared at least once with placebo satisfies the assumption of transitivity and allows the inclusion of all studies in a single model that can combine direct and indirect evidence as if all treatments had been compared with each other in their effectiveness with respect to placebo. Within the overall network of comparisons, it was evident that the effect of the large majority of nutraceutical preparations did not reach statistical significance. The ranking generated from the combination of direct and indirect evidence revealed that the only treatments potentially useful in significantly improving the erectile function score compared to placebo were L-arginine alone but mostly in combination with tadalafil, and the propionyl L-carnitine acetyl L-carnitine mix alone but mostly in combination with sildenafil. Therefore, as expected, the best results were obtained in the presence of a phosphodiesterase type 5 inhibitor. Acetyl and propionyl L-carnitine participate in the complex shuttle activity that carnitine exerts at the mitochondrial level to produce energy from the beta oxidation of long-chain fatty acids. In fact, L-carnitine, once transported into the mitochondrial matrix, can be generated from both of these substances. This process can facilitate the clearance of peroxidized lipids from the cell membrane, blocking the oxidative chain and improving endothelial cell function overall. In the same cell, L-arginine acts as a substrate of nitric oxide synthase, thus increasing nitric oxide levels, which, by activating guanylyl cyclase, leads to the synthesis of cyclic GMP. Obviously, these activities taken together are enhanced by phosphodiesterase type 5 inhibitors that maintain high intracellular concentrations of cyclic GMP. A separate mention deserves vitamin D, to which beneficial effects on sexual and reproductive health have also been attributed as part of increasingly ubiquitous pleiotropic activities. Most of the disorders somehow related to vitamin D deficiency, including erectile dysfunction and hypogonadism, are particularly common in the elderly, and preclinical studies suggest the basis of possible pathophysiological associations. As for erectile dysfunction, vitamin D, in addition to being an important micronutrient in the maintenance of penile cytoarchitecture, can stimulate endothelial nitric oxide synthesis, as shown in this study in which human umbilical vein endothelial cells were used. This increased generation of nitric oxide would reflect the induction by vitamin D of endothelial nitric oxide synthase, as mice carrying a mutant functionally inactive vitamin D receptor are characterized by both lower bioavailability of nitric oxide and lower expression of its synthesizing enzyme. Supported by this preclinical evidence, some studies have shown a significantly lower erectile function in the International Index of Erectile Function Score in men with deficiency compared to controls with normal vitamin D levels. And other authors found significantly higher vitamin D levels in men without erectile dysfunction when compared with patients with erectile dysfunction. However, it should be considered the high heterogeneity among these studies due to differences in the study populations and also to the different methods of vitamin D measurement that could affect the results. Furthermore, almost all of these studies included the cohorts of patients with comorbidities such as diabetes, renal failure, hypogonadism, prostatic hyperplasia, which in themselves are well-known causes of erectile dysfunction. The existence of a direct causal relationship between hypovitaminosis D and erectile dysfunction could be definitively proven by intervention studies aimed at testing the effect of vitamin D supplementation on sexuality. Unfortunately, very few such studies are available. In this prospective study, 102 men with erectile dysfunction and vitamin D deficiency were given oral supplementation that could normalize the vitamin D levels and monitored every 3 months. The erectile function score progressively increased in a significant manner during the follow-up period. In this subsequent Italian study of a cohort of patients evaluated for sexual dysfunctions, authors demonstrated a very strong positive correlation between vitamin D levels and scores of different dimensions of the International Index of Erectile Function. However, in a subgroup of patients studied longitudinally before and after vitamin D supplementation, a significant improvement was found only in the erectile function subscore. Unfortunately, these two studies are not randomized controlled trials and therefore could not be included in our network meta-analysis on the effect of nutraceuticals in improving erectile function. Another mechanism by which vitamin D may modulate erectile function and more generally male sexuality is through a complex relationship with testosterone. Vitamin D appears to be partially dependent on the testis for its activation, but in preclinical models it would be able to directly induce testosterone biosynthesis in Leydig cells. Unfortunately, despite this basic background, moving on to clinical studies, a number of still open questions do not allow the relationship between hypovitaminosis D and androgen deficiency to be definitively defined. In this large meta-analysis from our group, the pooled standardized mean difference revealed a slight, albeit just significant, positive association between vitamin D and total testosterone levels, once again with a large between-study heterogeneity. To identify the possible source of the differences in results among the studies included, in a subgroup analysis, pooled estimates were calculated separately for studies enrolling community-dwelling men, or otherwise without documented systemic illnesses, and studies carried out in frail populations. As you can see, a significant positive association along with noticeable decrease in heterogeneity could only be demonstrated in studies of patients with frailty states. Whether or not a causal relationship actually exists between hypovitaminosis D and androgen deficiency has so far not been defined even by intervention studies. The available trials do not seem to show that vitamin D administration is associated with a significant increase in circulating testosterone level. Actually, uncertainty remains because study populations were not always selected for androgenic deficiency nor for hypovitaminosis D. So, in conclusion, In the context of the widespread low efficacy of most nutraceutical preparations, the network meta-analysis approach identified a restricted group of compounds potentially useful in erectile dysfunction, that is, L-arginine and carnitines, alone but mostly in combination with phosphodiesterase type 5 inhibitors. These substances could play a role in enhancing the effects of phosphodiesterase type 5 inhibitors without increasing the doses and thus downsizing the side effects. However, important open questions remain regarding doses, treatment duration, and selection of patients to be treated. As for vitamin D, in many patients, the association between androgen deficiency and hypovitaminosis D appears to be an expression of health-related risk factors shared by both of these conditions. However, randomized controlled trials on hypogonadal patients with vitamin D deficiency are needed to clarify causal relationship definitively. And I thank you for your attention.
Thank you very much, Dr. Barbonetti. I think it's very interesting talk because we always use nutraceuticals, but the question is, what is your recommendation if you have a young patient with moderate erectile dysfunction and it's the first time patient in your office? Do you recommend nutraceutical as a single treatment option or always in combination as a dual or multimodal therapy in the treatment of moderate erectile dysfunction?
On the basis of the results of this network meta-analysis, but on the basis of the main studies exploring this topic, the best approach is the combination of tadalafil on demand at the daily dose of 5 milligram in combination with L-arginine. L-arginine at the dose of above 2 gram daily. Because there is a rationale for the pharmacodynamic effect due to the effect of arginine as a precursor of nitric oxide and the effect of phosphodiesterase type 5 inhibitor. When used alone, L-arginine can be considered only in the presence of mild moderate erectile dysfunction, but not for severe erectile dysfunction.
And do you recommend to start with PDE5 inhibitors and then to include L-arginine?
Yeah.
Both together.
There is some evidence. There is some evidence that in the presence of endothelial dysfunction, there is a depletion of L-arginine. Therefore, the best approach is to start with L-arginine and to include as a second step the tadalafil with a daily dose.
Thank you. Maybe last question. I was very impressed by the clinical data of vitamin D.
Yeah.
And it's very interesting, especially in relation to testosterone and testosterone level. And I think for you Italian guys, it is easier to tank vitamin D, but in north of Germany, it is always a problem. And the question is, if you have a patient in your office with erectile dysfunction and changes in his vitamin D level, what is the level? When do you recommend to start using vitamin D as a additional treatment together or as a single option together with testosterone? What is the level or orientation for clinicians?
There is a recommendation to use vitamin. There is a recommendation to use vitamin D in the presence of vitamin D deficiency below 30 nanogram per milliliter. Because above 30, we are in an optimal condition of vitamin D. But this is important regardless the vitamin D effects on testicular function, but for all pleiotropic effect of this vitamin, in my opinion.
Thank you very much. And we are moving on to our next speaker, Dr. Gomez, and he will talk about nutraceuticals in the non-surgical treatment of erectile dysfunction. Dr. Gomez, please.
Good evening to everyone. First of all, I want to thank you, Giovanni Corona and Carlo Betocchi, as current and past president of the ESSM, and Mikel Fode as president of the scientific committee for this opportunity. I am trying to put some light about the hope and reality of the nutraceuticals in the non-surgical treatment of erectile dysfunction. Nutraceuticals are any food or part of it that offer or are supposed to offer medical or health benefits, including the prevention and treatment of diseases. They are commonly taken as purified food supplements in pills and are proposed to be safe, with no side effects, and with many therapeutic benefits, and people see them as natural remedies. They are not regulated by agencies as the FDA or EMA in the same way other drugs are, and erectile dysfunction as an unreported condition becomes a perfect target for these therapies, given that there is no need of prescription and no need of visiting the doctor. Some facts about history. Many cultures and societies have proposed different remedies to treat ED. In ancient Greece and Rome, men wore talismans of rooster or goat genitalia, as long as they thought this would promote sexual function. The first evidence of nutraceuticals are from the Roman Empire, when men consumed the genitalia of animals with high libidos, such rabbits, and drank the semen of hawks and eagle to promote this erectile function. In the 13th century, the friar Albertus Magnus suggested to ingest a wolf-roasted penis, and in the 18th century, Dr. Samuel Salomon created a balm composed of cardamom, brandy, and cantharides, which was applied into the scrotum in a cold water bath. 1 century later, the idea of testosterone playing a role in sexual function led to several investigations from that age. In France, for example, Dr. Brown-Sequard injected himself extract from the testicles of dogs and Guinea pigs to see the improvement on sexual function, and in Russia, Dr. Osmonov performed testicular graft transplantation from apes to humans. But even nowadays, many animal species are sadly illegally traded due to the ancestral beliefs in their potential of relieving some health conditions, including ED. And we all have in mind the pangolin example that was suspected to be one of the origins of the pandemic, of the COVID pandemic some years ago. But apart from the magic effects on some of these nutraceuticals, some of them have been investigated in scientific ways. So we are trying to put or to resume the scientific background between some of them. The first of all is L-arginine. I put it the first because it's the most studied nutraceutical for erectile dysfunction, and I don't know if it is the most used. It's supposed to be, but This kind of therapies are difficult to establish. It's difficult to establish the number of sales of this kind of therapies. So it is supposed to be the most used, but some questions are arising. It is an amino acid obtained by the diet and the endogenous metabolism, and it's a substrate of many enzyme pathways involved in the regulation of vascular tone, immune activation, and cell growth. Is catalyzed by the nitric oxide synthetase to obtain nitric oxide, and this increase in the nitric oxide is supposed to improve ED. The main problem of the L-arginine is that in many times it is presented in combination with other nutraceuticals, for example, citrulline, selenium, vitamin E, etc. But in this meta-analysis, comparing the effect of arginine alone and arginine in combination with many others, for example, joinvine, that we will be speaking later, we can see there is a trend favoring the treating with L-arginine. But if we want to see the effect of L-arginine alone, we can take these studies here. This is from a recent meta-analysis, systematic review and meta-analysis, very well done and very complete. There are two studies comparing L-arginine alone against placebo in vasculogenic patients, and two other studies comparing L-arginine against placebo in all time of erectile dysfunction. We can see in vascular patients that there is a clear and significant improvement in erectile function, but this improvement is not that good, in patients with all kind of erectile function. The main problem in these studies is that the dose of the L-arginine is very variable. You can see from 1,500 to 6,000, and an issue of many of L-arginine and any other nutraceuticals is the duration of the treatment, because we can see here from 17 days to 3 months, but we don't know if the effect of nutraceuticals is long established or we have to take them forever. As you can see, the scores of patients with vascular erectile dysfunction are much better with L-arginine comparing to placebo, and in those patients with all kind of erectile dysfunction, these scores are better with arginine, but in one study they did not reach statistically significance. Another setting is combining L-arginine with PDE5s. There are many studies comparing in different ways, and if we take PDE5 versus L-arginine, we can see that taking PDE5 is better. If we take PDE5 plus arginine versus only arginine, we can see that the combination is much better. And if we take PDE5 plus arginine versus only PDE5, we can see that the combination is slightly better, but in some cases it is not statistically significant. So let's go for the next nutraceutical, Tribulus terrestris. Tribulus terrestris is a plant originally from Bulgaria. Its extract is rich on saponin esteroids as protodiostin, which is supposed to have an effect on hypogonadism, urinary symptoms, and erectile function. There is another saponin esterase, diosgenin, which have a protective effect on microcirculation. And it has been investigated in men with mild to moderate ED, with or without hypogonadism. As you can see in the 3 studies that compare Tribulus terrestris to placebo, we can see there is a trend favoring Tribulus terrestris, but in one case we did not find any clinically or statistically significant difference. And if we think that this effect is due to the testosterone boost it produces, a recent meta-analysis, find that most of the studies did fail to demonstrate that the Tribulus terrestris increase total testosterone. Next page, Panax ginseng, also known as Korean ginseng, is supposed to have an antioxidant, antidiabetic, immunomodulatory effect, including aphrodisiac properties. These effects are the results of many metabolites with high pharmacological activity in many cell targets. So the problem here is which metabolite has the effect on erectile dysfunction, and if we can know which one is, why not administer this metabolite instead of the Korean ginseng? There are 5 studies investigating the effect of Korean ginseng. As you can see, all kind of erectile dysfunction patients were included in all of them, with very similar regimes of duration of the intake, but different doses, as you can see here, from 800 to 3000. You can see the scores of the questionnaires. An increase in all of the cases was observed, but if we see the charts of the meta-analysis, you can see that there is a tendency favoring the intake of ginseng, but in some of the cases this difference did not reach statistically significance. Another nutraceutical is vitamin D. Vitamin D has been studied only in combination with daily tadalafil or tadalafil alone. 2 studies involving over 200 patients, all of them with vitamin D deficiency, were included. So in this case, we cannot know the effect of vitamin D on erectile dysfunction itself, because the effect is supposed to be a general improvement on the health of these patients. But as you can see here, significant clinically and statistically improvement was observed. Joinvine is a extract from a common tree in West Africa. It's an alpha-2 adrenoreceptor antagonist that increases parasympathetic mimetic activity and reduces sympathetic activity, allowing an increase in blood supply to the cavernosum tissue. This increase in the blood supply is supposed to improve erectile function, but most papers date before the release of sildenafil, when psychotherapy and intracavernosal injections were the gold standard. So because the studies we have today do not use validated questionnaires, and they use instead the nocturnal penile tumescence to evaluate the effect on erectile function. You can see in almost all of them there is a improvement in this nocturnal penile tumescence, but the main thing here is that the effect or the effect of this improvement is very low. Vitania somniferan, also known as ashwagandha, has been used for centuries in Indian medicine. Its root extract contains alkaloids, flavonoids, and tripterpene lactones. In vitro studies demonstrated the plant to be anti-inflammatory and to have anti-diabetic and cardioprotective effects, but the quality of these studies is controversial. In fact, when studying Vitania somniferan for erectile dysfunction, we can see two studies. In these two studies, we see controversial results, so no effect on erectile dysfunction is supposed. Euricoma longifolia is an herb traditionally used in Malaysia as a remedy for vitality, energy, and for its aphrodisiac effects. Animal models have shown changes in male libido and sexual motivation activities, but the pathophysiology baking their effect in ED remains unclear. There are two studies investigating the effect of Euricoma against placebo, with different regimes and different doses, but they include all types of erectile dysfunction patients, and as you can see, there is a slight improvement. The other one is Crocus sativus, or saffron, that is supposed to have an aphrodisiac effect on some animals and humans, but it has only been investigated in patients taking antidepressants and suffering erectile dysfunction. And as you can see here, there is an increase in the punctuation of the questionnaire. Next one is Pinus pimaster. It's a pycnogenol in an extract from French maritime pine, so a polyphenol. It has antioxidant and multiple biomodulating effects, among them the reduction of glucose levels and adjusting lipid profile. And these effects are supposed to improve some etiogenic causes of ED. There are two studies with similar regimes and the same dose. And as you can see, there is an improvement on EE5 punctuation in contrast to placebo. So, take-home messages. Many nutraceuticals do not refer to single molecules, so its effect in sexual function cannot be clearly established. Although there are RCTs about some of them, the lack of an adequate number of patients for these settings. Also, inclusion and exclusion criteria should be more restrictive, and most promising results are those shown for L-arginine as a single or combined treatment with PDE5s, especially in vascular ED population. Thank you so much. That's all.
Thank you, Dr. Gomez. We will open discussion, and please feel free to write your question in the Q&A section. I have a question concerning nutraceuticals and use of shockwave treatment. Are there any studies, or do you have any evidence on a combination with shockwave treatment and nutraceuticals?
Not as long as I know, but it could be interesting because especially with L-arginine, that is supposed to be a molecule that improves oxide nitrate, the effect of shockwave therapy could be interestingly studied in that clinical setting, I think. But as long as I know, there is no current evidence about that. I don't know if Archangelo.
Dr. Barbonetti? I have another question. Well, as you mentioned, and also during the first presentation, the main problem is the lack of randomized controlled trials. And we have no standard protocols how to treat patients. We have standard protocols to treat patients using PDE5 inhibitors, but not with nutraceuticals. And if always in combination with, as we discussed, tadalafil. Please share with us with your experience how to use L-arginine in daily dose, for example, with tadalafil. And what is your criteria to evaluate success or maybe non-response of the treatment? How long should the patient be treated with the combination of PDE5 inhibitors and L-arginine, for example?
In my personal experience, I don't usually use them in daily clinical practice. I know that there are presentations with PDE5 inhibitors and L-arginine that combines both of them, and people find them in some clinics or in some pharmacy offices, and I'm not against it, but I don't use it because it can increase the price of the treatment, and not so many patients are want to take them together. So I don't really have a real clinical experience, but I think that in vascular patients, we have a lack of randomized controlled trials, but it's not only the lack of those studies, is that in all the literature, there is a very laxus inclusion and exclusion criteria. For example, maybe the best benefit of arginine could be observed in those patients with vasculogenic ED. Why not only take those patients to see the real effect and do a proper RCT to know the exact effect? Of course, we could do that in combination with PDE5 inhibitors.
Thank you. I have a question to both speakers. You mentioned very fancy Indian, Bulgarian, Korean, Malaysian products which are used to produce nutraceuticals with a significant effect of most of them on testosterone level. And so, as you already mentioned, we know a lot from the history about the nutraceuticals, but we don't know everything about the efficacy of these substances. And my question is to both of you, do you think that nutraceuticals have a future in the post-PDE5 inhibitors era? Should we really initiate another studies on hopefully randomized controlled studies, placebo-controlled studies, or this is probably the fate of this method of treatment to be just additional part of the common treatment or common protocols in the treatment of erectile dysfunction? Dr. Gomez, please.
Yes. I think that there is still an opportunity, but the main thing here is which is the effect, which is the molecule, which is the part of the nutraceuticals that produce the benefit. With L-arginine, we can just extract L-arginine and do a correct RCT, and I think that it has an effect, a real effect on people with mild or moderate ED. But when we are speaking about, for example, the tribulus terrestris is an extract, you know. It's very difficult to know which molecule is doing the effect and what is the dose of that molecule, you know. What are we taking? We don't really know the exact amount and the molecule that we are taking. So how do we control the effect, the real effect, or something that we don't really know what we are taking? That's my question.
Thank you. Dr. Barbonetti.
I agree, and as is evident from results I showed with the network meta-analysis, with this approach it is possible to restrict the range of nutraceuticals to a very few molecules, and this is the first step to select very few molecules that can be used in focused RCT in the future, with a combination, in my opinion, with phosphodiesterase type 5 inhibitors. Because alone the effect is not very important.
Thank you. Well, we have very interesting comment from Turkey, from Dr. Bahadir. And she wrote that she used for clitoris and penis, I always recommend vitamin D or L-arginine to my female patients with arousal disorder. So it works. Well, today our both lecture were addressed basically to men's health, but maybe you have some data or experience of use of nutraceuticals in women health in gynecology.
I know that there is a systematic review that indicates a possible utility of L-arginine, for example, in hypoactive desire in women. But I have no experience in this field.
Dr.
Me neither. I don't have experience with in women, and I don't know which is the basics of that effect.
So this is very interesting phenomena, because we all always or nearly always talking about men's health, but we're paying too less attention to female sexual health. And I think that this comment was very important, and I want to announce our next webinar, which is on 18th of December, and we will explore regenerative treatment options in female health. Well, thank you very much. It's good timing. I want to congratulate both speakers for terrific presentations. Thank you for your hard work, and I hope to see you next month on our last webinar in this year. And of course, try to find time and join our annual meeting in beautiful Italy. Thank you very much. Have a nice evening.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye-bye.